Good afternoon. Now, this afternoon for topic A, I wrote a little narrative about long-term care system is collapsing in slow motion, and we're pretending not to see it. Okay, I'm going to go into detail for that one. So we shall get going on A today. Sit back and please enjoy. Health system health system executive and palliative care specialist. Okay, here we go. Miss Green's fall is the one that left her on the floor for hours, dehydrated, frightened, and apologizing for being a bother. Was not an accident. It was the predictable outcome of a long-term care system that has been structurally unsound for decades. Her story is not an anecdote. It is a data point in a national trend, line, line blending toward crisis. We are entering an era in which adults over 80 are the fastest growing segment of the population. Functional impairment, dementia, multimorbidity, and social isolation are rising in parallel. Yet the United States continues to operate long-term care as if it were a private matter, a family responsibility, a personal failing, or a lifestyle preference, rather than a public infrastructure challenge on par with transportation, water systems, and broadband. The result is a system that fails older adults, burdens families, destabilizes hospitals, and drains state budgets, all while pretending that aging in place is a strategy rather than a slogan. The financing architecture is unsustainable, and the math is no longer debatable. The United States is the only wealthy nation without a dedicated long-term care financing mechanism. Instead, we rely on a three-legged stool that is already broken. Medicaid, which requires people to spend down to poverty before receiving support. family caregivers who absorb billions in unpaid labor, lost wages, and health consequences. Private long-term care insurance, which has contracted dramatically due to flawed actuaries, assumptions, and rising premiums. This structure is not merely inadequate, it is mathematically impossible to sustain. As the population ages, the demographic curve is fixed. The financing model is not a rational system. Would include catastrophic coverage for high cost, long duration needs, universal LTC insurance to spread risk across the population, or public-private hybrid models that prevent families from falling off financial cliff. The moment dementia or disability enters the picture, without financing reform, every other policy intervention is a patch on a failing roof. Temporary, insufficient, and designated to collapse under the weight of demographic reality. The workforce crisis is the system's most immediate and dangerous threats. Long-term care is powered by direct care workers, home health aides, personal care attendants, certified nursing assistants, they perform physically demanding, emotionally complex, deeply skilled work, yet they are paid less than workers in retail or hospitality. The consequences are predictable and devastating. Vacancy rates above 20% in many regions, turnover exceeding 50%, home-based services going unstaffed, nursing homes closing wings or entire facilities forced into unsafe caregiving arrangements. Hospitals unable to discharge patients safely. This is not a labor shortage. It is a policy engineered scarcity created by reimbursement rates that do not reflect the true cost of care. A sustainable system requires Medicaid rate reform tied to actual labor costs, career ladders, and credentialing that professionalized workforce, portable benefits that stabilize employment, immigration pathways to direct or immigration pathways for direct care workers to fill unavoidable demographic gaps. Without workforce stabilization, aging in place becomes aging without care. Dementia is the policy blind spot driving the crisis. Quietly, predictability, and catastrophically, dementia is the condition most likely to push families into financial and emotional collapse. It is also the condition our policies are least prepared to support. We have no national dementia care benefit, no guaranteed respite, no standardized navigation, no integrated medical social care model at scale, no predictable funding for behavioral health supports. Families are left to improvise care for one of the most complex diseases in medicine, a disease that affects memory, judgment, mobility, sleep, behavior, and safety. A rational system would include dementia capable care coordination, mandatory navigation, respite benefits, and predictable financing that prevents caregiver burnouts. A major driver of hospitalizations, institutionalization, and Medicaid spend down. Ignoring dementia is not a policy stance, it is a policy failure. Housing is the silent detriment of long term care and the most overlooked. We talk about long term care as if it begins with a diagnosis. In reality, it begins with a staircase. Most American homes are not designed for aging bodies. Narrow doorways, slippery bathrooms, multi-story layouts, car-dependent neighborhoods, poor lighting, lack of grab bars, ramps, or accessible showers. Aging in place without accessible housing is not independence. It is risk. Risk of falls, isolation, malnutrition, medication management, and preventable hospitalizations. Policy must address accessible housing stock, home modification subsidies, zoning reform for multi-generational and supportive housing, transportation infrastructure for non-drivers, integration of housing and health funding systems or streams. Housing is not long-term care policy. We just refuse to name it. Hospitals are absorbing the system's failures and paying the price. As long-term care capacity erodes, hospitals become the default safety nets. Patients remain in beds for weeks, awaiting placement. Emergency departments fill with older adults who cannot safely return home. Readmissions rise because home supports are inadequate. Length of stays balloon. Health systems absorb costs that should belong to the LTC infrastructure. This is not a hospital operations problem. It's a long-term care policy failure with downstream clinical, financial, and workforce consequences. Hospitals are the canary in the coal mine, and the coal mine is filling with older adults who have nowhere else to go. The path forward requires treating aging as infrastructure, not charity. If we reframed aging the way we frame roads, water systems, and broadband, the policy path would be obvious. We would invest in home and community-based services, workforce stabilization, and wage reform, dementia capable care. Give me 1 second, folks. I'll finish the rest of this. 1 second. Accessible housing and transportation, care coordination and navigation, predictable population level financing. We would stop relying on daughters to quit their jobs. We would stop forcing older adults to spend down to poverty. We would stop pretending that independence means doing everything alone. Support is what makes independence possible. The choice before us. Mrs. Green's fall was not a personal failure. It was a policy failure, the kind that repeats itself every state, every day, in homes where older adults are trying to manage alone because the system designed to support them was never built to scale. Long-term care policy is not about nursing homes or Medicaid budgets. It's about whether we believe aging is a shared chapter of life or a private burden. The demographic curve is non-negotiable. The policy response is not correct. Okay, guys, that's your A for this afternoon. Let me take a little break and I'll be back on with B very shortly. Okay? For now, Gator Wellness, take care, folks.